think I invite Dr. Palajani, sir, for this talk, AMI with multi-vessel disease.
I have actually taken the liberty of changing the title of my talk. The reason is that acute myocardial infarction, just multivessel disease, becomes a purely an interventional talk, and lot has been written about few years back whether one should do the infarct-related vessel or one should do the complete revascularization. So what I thought, I will speak on the myocardial infarction, multivessel coronary artery disease, LV dysfunction. What are the management strategies? I think a lot of it has been discussed in last couple of years. So since it is the talk or the whole conference is on the top 10 recent advances, I thought I'll tackle this particular aspect of the coronary artery disease. Just to start with, this is a very evident case. A patient has got an acute myocardial, anterior wall myocardial infarction. It's a 75 years female, presented at some nursing home, treated with TNK, breathlessness, came back to us after 3 months with breathlessness, class 2 New York Heart Association, diabetic and OHA, non-hypertensive, and the ejection fraction when she presented to us was 30%. And this you can see when she presented, she had a tight left main ostial lesion, a total occlusion of the right coronary artery, and a total occlusion of the circumflex artery as well. Now what happens in these patients when they develop a myocardial infarction? It is known to all of you that when a myocardial infarction occurs, there is a rise in the left ventricular end diastolic pressure, left ventricular filling pressure increases, there is an increase in the dimensions of the left ventricle, there is a microvascular dysfunction, mitochondrial dysfunction, leading to reduced oxygen delivery and leading to progressive cardiac failure. Now, in our country, the incidence of heart failure is very common. However, the commonest cause of the heart failure burden is basically related to myocardial infarction, and it is estimated that close to 2.1 to 8.4 million patients in our country have got acute myocardial infarction, which results into the left ventricular dysfunction and failure. Now what happens when a patient develops myocardial infarction and how do they recover? There has been a study called as a PREDICT study in which at the end of 90 days, patient's ejection fraction was calculated, and if the patient's ejection fraction was less than 35%, they were followed up for a couple of years and found that persistent severe reduction in the ejection fraction of less than 35% was present in close to 43% of the patients. So patients who develop a myocardial infarction, if you study them at the end of 3 months, you find that the patient's ejection fraction is low. Take it for granted that your patient is going to have a reduced ejection fraction. He is going to have possibly a multivessel disease. So what are the options available to us for these patients? In addition to the GDMT, that is guideline directed medical treatment, we have got a bypass surgery, we have got an angioplasty, stenting, where we can do a multivessel angioplasty. Now we'll, in the next course of few slides, we'll see what is the best optimum treatment for these patients. Now STITCH trial has been already touched upon by Dr. Satyavan Sharma, and it was a randomized trial. It was on 127 clinical sites. The coronary artery disease was amenable to CABG with ejection fraction of less than 35%. 602 patients underwent medical therapy and 610 underwent the surgical therapy. The basic thing was to decide whether the surgical treatment had any impact on the survival in these patients who had a multivessel disease, myocardial infarction, or no myocardial infarction, but they had a reduced ejection fraction of less than 35%. What they found on the follow-up, that though the death from the cardiovascular causes was better or lower in the CABG group, Death for any cause of hospitalization for heart failure was again less for the patients with CABG. The primary outcome of rate of death from any cause was no different between the two groups of patients, whether the patient received the GDMT or that the patient received the CABG. The outcome was no different between the two arms, suggesting that even the GDMT was good enough. And this is the curve over 6 years period, and you can see that the probability of death from any cause was no different in two arms. However, then came the option of subjecting these patients to an angioplasty and subjecting them to the everolimus eluting stent versus coronary artery bypass graft surgery. Now I must tell you, this was not a randomized trial. What I am quoting was not a randomized trial. It was the trial or the data collected on 4,600 patients from New York Heart Registry, and some 1,351 patients received everolimus eluting stent, 3,200 underwent CABG. Primary outcome was all-cause mortality. And what you see here, that the everolimus eluting stent, drug-eluting stent, did as good as the bypass surgery, indicating that if the patient, you want to subject him to the angioplasty, he will have similar outcomes of death, myocardial infarction, and freedom from angina as compared to the CABG. This was thought because, as all of you know, CABG is a very cumbersome procedure. Cutting open the chest, patients stay in the hospital for more than 7 to 10 days. However, angioplasty, you can just put in a stent, open up the vessel, and send the patient home after 48 surgery, after angioplasty. However, trial after trial has shown that though you may get away with a good outcome, immediate outcome, if you follow up these patients over a period of years and compare them with the CABG, you would find that the left ventricular function tends to go down progressively in the patients who undergo PCI, indicating that in this patient, CABG is superior to the patients who undergo PCI. Similarly, improvement in the ejection fraction over years is far better in those patients who underwent a bypass surgery as compared to the patients who underwent PCI. This is a trial which again has been, actually this is the one which has been quoted, off-quoted, and this is the latest trial which indicates what is the value of performing an angioplasty in these patients who have had a ischemic heart disease, have multivessel disease, low ejection fraction of less than 35%. I think Satyavan Sharma again alluded to this particular trial called as the REVIVE trial. In these patients underwent OMT, that is optimum medical treatment alone, compared to the PCI with OMT. And what was the end point? All-cause death or hospitalization for heart failure, and the minimum follow-up was for 2 years. And what one found, that the angioplasty was no good. The results of angioplasty over 8 years following randomization showed that the PCI as well as the optimum medical treatment has similar outcomes, indicating that the angioplasty is perhaps is as good or not as good as the optimum medical treatment. So why there are no long-term benefits in these patients, whether when you look at the angioplasty or whether you look at the bypass surgery? Because it is just not the obstruction in the vessels that matters. Most of these patients have got multivessel diffuse disease. Many of them, because of the chronic disease, have got a microvascular disease. There has been a left ventricular remodeling, reverse remodeling, in which the left ventricle is distorted. So even if you did a bypass surgery or did an angioplasty, this doesn't get corrected at all. There are large scars which don't improve after doing an angioplasty or bypass surgery. Many of them have life-threatening arrhythmias, and therefore Many of them who have been subjected to angioplasty or to the bypass surgery never evaluated with a Holter monitoring or with the EP studies whether these people will need an ICD or will need a pacemaker. Several of them have got a mitral regurgitation. So therefore, when the patients were subjected in STITCH trial, many of them had a left ventricular reconstruction surgery as well as replacement of the mitral valve. So until unless you do a complete revascularization and complete correction of the mechanical surgical defects, patients are not going to do well. So therefore, to summarize it, what are the AHA guidelines for these patients who have got severe left ventricular dysfunction, multivessel disease, following some myocardial infarction or chronic ischemic heart disease? AHA gives them class 1 indication to surgery. Left ventricular dysfunction, multivessel disease, severe left ventricular dysfunction less than 35%, CABG is recommended as a class 1. However, a class 2B is given to these patients who are not amenable to surgery because of the comorbidities. You may perform a PCI to improve their symptoms, but however, the survival benefit is not certainly documented. So therefore, ladies and gentlemen, in these patients, if you see a patient who had a myocardial infarction, develop a severe left ventricular dysfunction, has a multivessel disease, in these patients, when you got given an option, either OMT, CABG, or PCI, if the patient's ejection fraction is too low, the best form of treatment in this patient is CABG. I'm sure, I'm disappointed, many of my colleague cardiologists who are angioplasters, they will also be disappointed. Thank you very much.